Here we are looking at the major components of the biliary system. The right and left hepatic ducts meet to form the common hepatic duct. The cystic duct, which drains the gallbladder, meets with the common hepatic duct to form the common bile duct. The pancreatic duct meets with the common bile duct to form the ampulla of Vater, which drains into the duodenum. In general, the presence of gallstones is called cholelithiasis. Most often, cholelithiasis is asymptomatic and is incidentally found on imaging. However, gallstones can cause problems. In symptomatic cholelithiasis, a gallstone can become temporarily lodged within the gallbladder neck or cystic duct, leading to biliary colic, often characterized as constant, dull, right upper quadrant or epigastric pain, which can radiate to the back or right scapula and typically lasts less than 6 hours. Vital signs and labs generally appear normal in these patients, but gallstones are often visualized on right upper quadrant ultrasound. The treatment for symptomatic cholelithiasis is elective cholecystectomy in order to reduce incidence of recurrences and complications. Acute cholecystitis occurs when the obstruction of the cystic duct becomes permanent. The stone does not dislodge, as in symptomatic cholelithiasis, and gallbladder inflammation ensues. These patients will present with fever, epigastric, or right upper quadrant pain, usually lasting greater than 6 hours, and this pain is often associated with nausea and vomiting. Lab findings show leukocytosis, and classic findings on ultrasound include the presence of stones within the gallbladder, pericholecystic fluid, gallbladder wall thickening, and a sonographic Murphy's sign. Treatment of acute cholecystitis is generally empiric antibiotics and cholecystectomy. A rare complication of gallstones being lodged within the cystic duct or gallbladder neck is Mirizzi syndrome, in which an impacted stone extrinsically compresses the common hepatic duct, leading to jaundice and lab findings indicative of cholestasis. If a gallstone is able to pass further down the biliary tree to the common bile duct, we call it choledocholithiasis. As with Mirizzi syndrome, there's a pressure buildup within the hepatic ducts, meaning there will be jaundice and cholestasis in addition to the typical right upper quadrant pain, nausea, vomiting, etc., seen with classic biliary pain. On ultrasound, it is uncommon to actually visualize a stone within the common bile duct. However, a dilated common bile duct is often suggestive of choledocholithiasis. Generally, the treatment for choledocholithiasis is ERCP to remove the obstruction and then cholecystectomy to prevent further incidences. There are important complications of choledocholithiasis. One is ascending cholangitis, which involves infection of the biliary tree, which can then spread to the liver and bloodstream, leading to septic shock. Normally, the passage of bile acts to flush enteric bacteria from the biliary tree. However, with prolonged stasis, the bacteria have a chance to ascend up the biliary tree. Therefore, a prolonged obstruction due to choledocholithiasis can lead to ascending cholangitis, as can other causes of obstruction, such as pancreatic masses. We use Reynolds pentad to describe the ways that these patients can present: fever, right upper quadrant pain, jaundice, hypotension, and altered mental status. Labs will often suggest inflammation and cholestasis, and blood culture should be drawn on any patient with suspected ascending cholangitis. Management involves identifying and addressing sepsis, administering antibiotics, draining the biliary system, most often via ERCP, and addressing the underlying cause, in this case, with subsequent cholecystectomy. Another important complication to remember is gallstone pancreatitis, which can occur due to high pressure backup through the pancreatic duct. Gallstones are the most common cause of acute pancreatitis, and these patients will additionally have elevations in their amylase and lipase levels on labs. As with ascending cholangitis, gallstone pancreatitis patients should generally undergo ERCP with subsequent cholecystectomy.